Hi, I'm a student at Western University of Health Sciences, class of 2021, and I'm presenting on the topic, Is your patient ready for spine surgery? So I'd like to warm up with an epidemiology study. A systematic review was conducted by Fatoye et al. 2019 with the purpose of generalizing the epidemiology of low back pain utilizing routinely gathered data, i.e. studies that utilize patients' electronic medical records. The studies included in this review were conducted in Belgium, Canada, Finland, the Netherlands, Sweden, USA, and Israel. The sample size used to estimate the prevalence and incidence of low back pain in the included studies ranged from 3,900 to 7.5 million. Population types include industry workers, military personnel, self-reported patients, and adults living in the USA, Quebec, and Sweden. They found the following. Mean prevalence for low back pain ranged from 1.4 to 20% of the total study population, with the highest incidence in the United States aerospace and defense industry, and the lowest incidence came from the residents of Quebec, Canada. I don't know what's so good about Quebec, but I guess it's good for back pain. Mean incidence for low back pain ranged from 0.024 to 7%. So we also found out gender may be a factor that leads to disposition, with 3 of 6 study reviews with an odds ratio greater than 1 suggesting being male as a risk factor. And traditionally we learned in school that being a female puts you more at risk for low back pain, but since we're utilizing electronic medical records, I think it makes we're getting closer and closer to be able to find out the incident rate based on the country you're in, which is kind of cool and kind of scary. The biggest limitation of the study was due to the fact that they were relying on medical records for their inclusion criterion, and in developing countries, there is no such medical record. So I'd like to do a warm-up activity, guys. This is an image. I wanted to see what people see, and if anyone would like to point out what they see. All right. Yeah. So in L5S1, there's a missing nucleus, and it's impinging on the central canal there. These are the different images of that same section. At that level, it's a 6.5 millimeter disc herniation. And you can see on this image that the herniation is impinging on the canal there. So this is a patient case. This is patient case D, 23-year-old male with an 8-year history of low back pain. He has tried physical therapy and chiropractic care in the past. His current flare-up has increased intensity and constant duration of left lower extremity muscle spasms. So continuing his case, the patient completed 8 weeks of physical therapy with decreased low back pain, but continued lower extremity muscle spasms and paresthesia. The patient continued activities for 4 months following discharge from care with continued fear avoidance strategies until he had another flare-up while sleeping, and followed up when an orthopedic surgeon and elected to have an L5S1 microdiscectomy and partial laminectomy. Patient D is me. This is actually a picture of me right after that surgery. This was like 2 months after I had that operation. I think I still had the bandages on underneath my suit here. This is my first PT school interview. I didn't get in that year, but it's a pretty cool story. And I have another patient case for you guys. Patient case S. Patient is a 71-year-old male who presents to physical therapy today with an insidious onset of low back pain with left lower extremity pain for 10 days prior. 3 days prior to his evaluation, patient's left big toe got caught in an elliptical. Patient was highly active prior to quarantine, and with his gym opening up again, he tried to return to 5 days a week lifting, and that's when he started feeling symptoms. Patient has been working for the past 3 years as a box maker, which requires him to fold together cardboard boxes quickly, frequently rotating to the right and walking across the factory floor to drop off the completed products. He has a significant past medical history of prostate cancer, prostatectomy without chemotherapy, which leads to his current urine incontinence. He has a history of carpal tunnel syndrome, a history of sciatica, and his current hemoglobin levels are trending downwards following his last blood panel. So, significant findings from this patient evaluation. Patient reports increased numbness and weakness in his left upper extremity. No significant changes in his myotomes and laterality. possible myotome pain in L5 that may or may not be consistent with his toe pain, and ataxic changes in his gait. The patient during evaluation was very concerned that this may have to do with the return of his cancer, and due to this, we agreed with his referring doctor's recommendation to get an MRI. So patient case S's return visits. In the following visits prior to patient's imaging, we were consistently measuring hand grip strength via a dynamometer, myotome testing, and gait speed. After treatments, patient's hand grip consistently trended upwards, but he continued to be fatigued. His gait speed will remain consistent before and after treatment. On the patient's second follow-up, we discovered changes in his L5 myotome, which we reported to his referring physician. Following his consult with his referring physician, they found an old odontoid fracture of C2 and a cyst at that level. Patient is currently referred to a neurosurgeon, is pending a follow-up appointment with them. In his treatments, we're focusing on maintaining patient's functional independence, safety, monitoring any significant changes in symptoms while he's pending an operation date. Patient has had some comments for how we deal with his case, and he said that initially he didn't know why he was coming to physical therapy because he thought it was, systemic. He reports he was confused by the purpose of all the tests and measures we were taking during his evaluation, and in the following sessions, he was starting to understand the benefits of the activities that we were doing with him, and he was really highly appreciative of the therapy staff ability to address and answer concerns that he had when he went to visit his doctor. So why was that important? I brought up those cases to bring up the importance of proper screening in physical therapy. In a study performed by Ladira 2018, a cross-sectional survey was conducted with 3 patient cases, low back pain with red flags for ectopic pregnancy, low back pain with orange flags for depression, and low back pain with yellow flag for fear avoidance behavior. In total, 3,000 PTs were reached out, but only 410 completely replied to the questionnaire. The results were compared among the following groups: orthopedic clinical specialists, PTOs, fellows of the AOMPT, PTOs and PTFs, and PTs without clinical specialization. 217 physical therapists managed the patient with low back pain and symptoms of ectopic pregnancy correctly. 115 therapists managed the patient with low back pains and depression correctly, and 177 managed the patient with low back pain and fear avoidance correctly. In general, physical therapists with specializations perform significantly better than their non-specialized counterparts in all 3 of the clinical vignettes. This suggests that there's improved screening ability with more education, and perhaps also that there should be more education emphasized at the entry level for the importance of the screening process and an appropriate course of treatment. And then the image on the right kind of is all I said, but visual if people are more visual learners. And in the table here, it breaks down in each individual category how many people succeeded in correctly treating each patient group. And as it shows, as you get more education, you tend to trend higher with better screening and treatment. So I've correctly screened a patient for spinal red flags. What happens next? So candidates for lumbar surgeries, when we catch a red flag in our practice, we send the patient back to their referring physician, and they send them to a specialist who will consider their case. According to the National Institute of Arthritis and Musculoskeletal and Skin Diseases, the following conditions may be candidates for surgical treatment. The important ones are back pain caused by a tumor, infection, or cauda equina, because those are time dependent. Other patients are herniated or ruptured discs, or those with herniated and ruptured discs, those with spinal stenosis, spondylolisthesis, vertebral fractures, and degenerative disc disease. So, the common lumbar surgeries, the National Institute of Neurological Disorders and Stroke lists the following as some of the surgical options for low back pain. The same National Institute also stressed there is little evidence to show which procedures work best for each particular indication. So these are some of the surgeries that I'll be discussing with you guys and kind of giving you an updated literature review. We have vertebroplasty and kyphoplasty, spinal laminectomy, spinal decompression, discectomy, foraminotomy, nucleoplasty, also known as a plasma disc decompression, spinal fusion, and artificial disc replacement. And as I said, the review of surgical interventions and literature regarding patient-reported outcomes. So vertebroplasty and kyphoplasty. Vertebroplasty is a procedure that fixates a vertebral fracture by injecting a quick-drying cement directly into the vertebral body to form an internal cast. A kyphoplasty is a procedure that fixates the vertebral fracture involving using a surgical device to expand the inside of the vertebral body back to close of its pre-fracture size and then being filled with a quick-drying cement. The first study I'll be discussing is an investigational vertebroplasty safety and efficacy trial, patient-reported outcomes through year 1. In an investigative study performed by Comstock et al. 2013, 11 sites in the US, UK, and Australia performed a study with patients' full consent to undergo either a vertebroplasty or a control procedure. The control procedure was applying local anesthesia and basically rubbing the area to make them think that they had a vertebroplasty. But that's not entirely ethical, so after 1 month, they were allowed to get the actual vertebroplasty if they wanted. So, 131 subjects were included in the study, 63 out of 68 patients in the vertebroplasty group, and 56 out of 63 patients in the control group completed a 1-year follow-up. There were 43 crossovers in total, 10 from the experimental group and 33 from the control. Conclusions: vertebroplasty group had a modest change in pain, but no functional disability changes per the modified Roland-Morris Disability Questionnaire. And it shows the trends on that graph, the graphs on the right. So, functional outcome of kyphoplasty in osteoporotic vertebral fractures in patients with severe disability above 60 years of age, mid to long-term follow-up. A retrospective study performed by Abdurrahman et al. 2021 followed 70 patients who underwent balloon kyphoplasty who were above 60 years of age, failed conservative treatment with a C radiological diagnosis of vertebral compression fracture, and the cohort was followed for 1 to 3 years. Conclusions: balloon vertebroplasty can improve patients' functional outcomes in mid-long-term follow-up with severe disability, defined as an ODI greater to or equal to 41. In the 3rd year, the ODIs went up from the previous follow-up, but still lower than pre-op. So based on their study, patients still had positive outcomes 3 years following their operation. The next surgery I'll be discussing is a spinal laminectomy or spinal decompression. A spinal laminectomy / decompression is where a portion of the posterior portion of the vertebrae is removed to alleviate pressure on the underlying nervous tissue. The study I followed for this was a patient-reported outcomes following lumbar decompression surgery, a review of 2,699 cases. In a retrospective study performed by Sunderland et al. 2021, they reviewed 2,699 lumbar decompression cases that included the Comey low back measure. Their analysis showed a mean average lower extremity pain improvement of 4 points at 3 months on the visual analog scale, mean average back pain of 2.61 at 3 months on the visual analog scale. Mean average improvement of the Comey was 3.15 for both primary and redo surgery groups combined. The MCID for the Comey is 2 points change. And after 2 years, 73% of the subjects matched that criterion. So conclusions: lumbar decompression is effective to improving quality of life in appropriately selected patients. Patient-reported outcome measures collected routinely and collated within a registry are a powerful tool for assessing the efficacy of lumbar spine interventions and allowing accurate counseling of patients perioperatively. And the graph on the right kind of follows the trend and shows them on like bar graphs of the trending outcome scores. So the association between payer status and patient-reported outcomes in an adult patient with lumbar spinal stenosis treated with decompression surgery. This prospective study by El Savid et al. 2019 followed a sample of 100 patients who underwent lumbar decompression surgery with the goal of determining if private or public insurance had an effect on patient-reported outcome measures. They utilized the VAS for leg and back pain, ODI, and the EQ-5D scores. Conclusions: public and private insurance has significant improvements across the board after electoral spinal surgery. However, patients with private insurance had a slightly higher EQ-5D scores at 3 months and 12 months follow-up. But that doesn't mean causation. There could be socioeconomical factors, like someone who can afford private insurance may have more that they want to get back to doing. The next surgery is discectomies. A discectomy is an operation where a surgeon removes the herniated disc material that may be impinging a spinal nerve root. They can be done via microdiscectomy, where the tissue is moved rather than cut, pericutaneously and endoscopically to minimize tissue damage when appropriate. The association of extended duration of sciatic leg pain with worse outcome after lumbar disc herniation surgery. A registered study in 6,216 patients. In a prospective study conducted by Beck et al., they utilized data from the Swede Spine, the Swedish National Spine Registry, and they apparently do a lot of the spine studies, which is cool. They included patients between the ages of 18 to 65 with primary lumbar disc herniations. They assessed patient response via numerical rating scale for leg pain, global assessment of leg pain, EQ5D, and ODI. Conclusions. Patients with the shortest leg pain duration, which is less than 3 months, reported superior outcomes in all measured parameters. More significantly, using a 12-month pain duration as a cutoff, patients who had a lumbar discectomy with a preoperative symptom duration of less than 12 months experienced a larger reduction in leg pain and were more satisfied with their surgical outcome and perception of postoperative leg pain than those with greater than 12 months of sciatic leg pain. So basically, the faster you can catch a patient that falls in this category, the higher chance they have for positive outcomes. And the next study for this topic is value in a single level lumbar discectomy, surgical disposable item cost and relationship to patient report outcomes. So basically that means their study was basically talking about does cost affect patient reported outcomes to their surgery. In a retrospective study performed by Rosenbaum et al. 2017 following a cohort of 652 patients at the Cleveland Clinic main campus between October 2009 and August 2013 who underwent lumbar discectomy, patient-reported outcomes were obtained from the Cleveland Clinic Knowledge Program Data Registry. They were trying to determine if the surgical cost had any impact on PROs. The PROs they used are EQ5D, PDQ, and PHQ9. Conclusions, cost did not have a significant impact on patient PROs except for the PDQ. The more expensive your surgeries, the poorer the PDQ outcomes. Next surgery I'm talking about is a foraminotomy. A foraminotomy is a minimally invasive procedure where a small incision is made under local anesthesia using an endoscope and a surgical drill to remove any bony spurs or thickened ligaments compressing the neuroforamina. Percutaneous endoscopic lumbar foraminotomy, an advanced surgical technique and clinical outcomes. So this is a longitudinal cohort study produced by On et al. In 2014. Overviews the surgical techniques and clinical outcomes for lumbar foraminotomy. They followed 35 patients that received the procedure between 2009 and 2011 and reassessed their VAS, ODI, and MACNAB. Conclusions, patients had improved scores across all outcome measures due to it being minimally invasive and performed under local anesthesia. Patients that were more medically sensitive could still have this technique done on them. So the next article is return to duty rates following minimally invasive spine surgery performed on active duty military patients in an ambulatory surgery center. This is a retrospective study performed by Granger et al. In 2018. They want to determine the surgical outcomes, return to duty rates, patient-centered outcomes in a cohort of 82 military members receiving a foraminotomy in an ambulatory surgical center. The results were 100% of the service members returned to duty within 3 months. Additionally, there was a significant reduction in self-reported pain and disability 12 months post-op, whereas the average length of surgery was 62 minutes with an average estimated blood loss of 30.64 milliliters. On the table on the right, you can see how each demographic of patients perform based on the total population, their gender, and their rank in the military. I didn't notice any significant changes between the different ranks, except for maybe the W01 to 08s had slightly lower outcomes, but I have no idea what that means, at least the rank part. Nucleoplasty, also known as plasma disc decompression. A nucleoplasty is a treatment for a minor disc herniation. Under local anesthesia, a fluoroscopically guided needle is inserted into the region with excess disc material. There, the needle is heated, creating an ablation field, destroying the disc material. This surgery is pretty cost effective, so they're trying all different types of techniques. There are some heat-based ones, they're trying radio frequency ones, electricity-based ones. But it basically started its own family of treatments. Annular nucleoplasty during disc surgery and the management of degenerative lumbar disc pathology. How long can the effect last? This prospective analysis performed by Kumar et al. 2018 followed a cohort of 51 patients who were 18 to 60 years old with a positive disc pathology, unresponsive to at least 6 months of conservative management, a pre-op VAS of at least 5, MRI revealing no more than 3 involved levels, and a Fuhrman's grade of 2 to 4. Conclusions: the patients followed had favorable outcomes in all measures, trending positively up for 2 years following up. ODI was at least positive trending throughout, but at the 2-year mark, 78% of the cohort met the MCID. The next surgery is spinal fusion. This is a surgical procedure to essentially weld multiple levels of vertebrae to heal into one bone. This is done to eliminate painful motion or provide stability to the spine. In this study, they compared hospital and surgical variation in patient-reported functional outcomes after lumbar spinal fusion, a statewide evaluation. This was a retrospective cohort study using data from the Washington State Spine Care and Outcomes Assessment Program with 737 qualifying patients to determine if ODI scores from 17 hospitals and 58 surgeons would yield different patient-reported outcomes. Their conclusion: patient-reported outcomes between hospitals and surgeon interventions had no significant difference between similar patient populations. The patients indicating diagnosis for spinal fusion was the primary cause of differences between the patient-reported outcomes in all these settings. In the next study about lumbar fusions, mild and severe obesity reduced the effectiveness of lumbar fusions. 1-year patient-reported outcomes in 8,171 patients. In this retrospective study performed by Mulvaney et al. 2021, following patients from 12 hospital systems, they want to determine if non-obese patients compared with obese patients that underwent level 1 or underwent 1 to 3 level elective lumbar surgeries without complications, and sought to compare the ODI from pre-op to 1-year follow-up. So the main criterion that was different was it had to be a successful surgery with no complications. They wanted to compare the healthy outcomes 1 year afterwards. Conclusions: in 1 year post-operative, all 3 obesity classes had worse mean ODI scores, ODI changes, and percent achieved MDI in the stepwise fashion when compared to the non-obese control group. Basically, that means the more obese the patient is, the more steadily poor outcomes the patient tends to receive after spinal fusion. The last surgery I'll be talking to you guys about today is an artificial disc replacement. In this surgery intervention, the involved disc is removed and replaced with a prosthetic disc designed to manage the natural movement of the spine, or maintain the natural movement of the spine. So this was a very interesting article I found. Long-term residual mobility and adjacent segment disease after total lumbar disc replacement. In this retrospective study conducted by Kitson et al. 2020, following 226 patients that received a total disc replacement from 1994 to 2000, with a mean follow-up of 16.7 years, to determine if mobility attainment and adjacent segment disease had an effect on patient-reported outcomes. Conclusion: of the 141 patients that followed for that long amount of term, long-term preservation of motion is only met in 1/3 of patients. So only 1/3 of patients meet the intended goal of the surgery. Residual mobility is a concept that even after fixating, sometimes the prosthesis rotates. So when they flex and extend, the prosthesis is not fully static. And it was categorized by a minimum of 4.6 degrees of rotation during the flexion extension radiograph. So residual mobility and the occurrence of adjacent segment disease do not have significant associated with long-term clinical outcomes. What this means is whether or not the patient has residual mobility occurring, or they get adjacent segment disease, which tends to be the deterioration of the disc around the fused level or the fixated level, where they can deteriorate and they get revision surgery. None of these factors affected their patient-reported outcomes. So even if they did well, that doesn't indicate if they will have to get further revision surgery. So mid to long-term results of total disc replacement for lumbar degenerative disc disease, a systematic review. This systematic review conducted by Siu et al. 2018 determined to look at the clinical effectiveness of total disc replacement surgery with at least 3-year follow-up. 13 studies met the criterion, 8 prospective studies, and 5 retrospective studies. Results across the 13 studies: the total disc placement intervention demonstrated a 51.1 to 70.5% VAS score improvement, 15.6 to 44.4 point reduction in the ODI at the last follow-up for each of the studies. Reported satisfaction rates range from 75.5 to 93.3. Complication rates in 11 studies ranging from 0 to 34.4%, and an overall reoperation rate of 12.1%. This study was also trying to compare if this was a sufficient comparable intervention when compared to lumbar fusion, and the results are currently inconclusive. They want to do more randomized control studies to compare the two groups, but nothing is completed yet. So now I have prehab considerations. I found a very interesting study between the association between physicians' communication and patient-recorded outcomes in spine surgery. The Hospital Consumer Assessment of Healthcare Providers and Systems conducted a survey with a cohort of 648 patients to determine if patient satisfaction with physician communication had an impact on PROs. Their findings was that it did not. So patient satisfaction with their physician's communication did not have greater improvements in PROs. This is not saying that they should have poor bedside manner, but depending on how the patient feels on the physician doesn't really affect their surgical outcomes. But they did find that better preoperative quality of life ratings indicated by a higher EQ-5DI score was associated with less improvement in 1-year PRO ratings, while conversely, the worse preoperative quality of life and pain ratings indicated by greater PDQ and VAS scores were associated with larger improvements in PRO measurements postoperatively. The worst self-rating of mental health was also associated with less improvement in patient-reported outcomes in the 1-year follow-up. I found another study on patient expectations and satisfaction in orthopedic surgery, a review of literature from the Journal of Clinical Orthopedics and Trauma. Patient expectations have been shown to be an independent predictor of outcomes in clinical medicine. This literature review is looking at the factors associated with greater preoperative expectations and postoperative satisfaction. And the two tables from that study show the factors associated with greater preoperative expectations in total hips and total knees arthroplasties. Patients with higher education, worse preoperative function, and history of arthroplasty have higher expectations. People undergoing soldier surgery, people with younger age, depending on their occupation, route of information about the disease, and worse functional status had greater preoperative expectations. In spine surgery, the younger you are, the greater your disability, and males tend to have greater preoperative expectations. And
I was just going to mention that what you're going through right now, I think is one of the more important ones, because this is how I think a lot of the philosophy goes in the spine center. That if you happen to be seeing a spine patient, these are some of the studies that are sort of backing that up. Yeah. And these are the studies that they're hoping that if you happen to have a spine center patient or chart that you're looking at, this is the way you should end up practicing, or at least using this data to sort of back up the situation.
Yeah, these studies kind of showing what leads to the best outcomes in recovery for patients undergoing these operations. So the factors associated with postoperative satisfaction for total hips and knees, meeting your preoperative expectations, improving in symptoms, functional improvement, and expectation of fewer complications. In shoulder surgeries, meeting preoperative expectations, functional improvement, improved general health, being married and being employed tend to have better postoperative satisfaction. And spine surgery, the main factor was meeting their preoperative expectations. The next study is early patient satisfaction following orthopedic surgery. In this study conducted by Howard et al. 2020, utilizing prospectively collected data from Maryland Orthopedic Registry, they analyzed patients underwent extremity orthopedic surgery from August 2016 to March 2018. 435 patients filled out patient-reported outcomes, NPS, expected domains of musculoskeletal outcomes data evaluation and management systems, and the National Institute of Health patient-reported outcomes measurement information systems, and a computer adaptive testing, and were compared with their patient demographics to determine if there were any associations. The results: greater surgical satisfaction 2 weeks following extremity orthopedic surgery associated with higher education, alcohol use, better scores on all 6 promised domains, greater activity levels, less pain, greater improvement, and greater met expectations. So I want to give you guys kind of a tool that you could use preparing your patient for surgery. So there's another study I brought up from Adrian Lowe about pain neuroscience education and which pain neuroscience education metaphors work best. In the survey, models were most effective to patients based on a survey of like 29 patients. No one visual model was more successful than another. All metaphors were determined to be useful for patient understanding of pain, but I brought 2 examples to you guys to kind of explain the patient experience. This is an image on the right with copyright permission. This is the hospital experiences model explaining to the patient why patients have an increased pain experience during their surgical experience. So as they get closer and closer to the surgical date, they kind of fixate on their symptoms, and that makes their body more sensitive to their symptoms. Therefore, go all the way going right into the surgery, they're more and more aware, and then when they wake up from surgery, that's all they're fixating on. So that's why they tend to be more painful on top of the actual surgical site incision. The next model I want to show you guys is the extra sensitive alarm model, explaining that with increased sensitivity there is little room for activity. So you have someone's baseline pain before surgery with a lot of room for activities, and once that alarm activates, so it could be a flare-up, it could be their surgery, they kind of peak, and then all sensation, or it takes less and less to make them feel that pain threshold sensation. And if they don't regularly bring it down to close to the baseline, they'll continue to be easily sensitized above that pain threshold. I know I talked fast, I know I went through a lot, but I wanted to end today with Lewis Gifford's 5 questions on what people in pain want to know. The 5 questions they have is, what is wrong with me? 2 is, how long is it going to take to get better? 3, is there anything I can do to help myself? 4, is there anything you can do to help me? And 5, how much it will cost? Every pain problem, acute or chronic, has a thinking, reasoning, and emotional brain attached to it. And I hope after today's presentation, even if you didn't get it all at once, you guys have a research to kind of go back and answer these questions when you see your patients pre and post operation. Thank you for your time. Thanks, everybody. Do we have any questions?
Go back to the other one. We're supposed to be opening a prehab section over here, and the one before this over here is generally the kind of education that most people get before going into surgery, whether it's knee or back surgery, I guess. But that launch system on the right side is the information that is received by the patient is actually sometimes responsible for actually ramping them up and increasing the failure rate of the surgery sometimes. So some things like procedures that go on to the surgery, some things where they talk about, okay, you're going to park here, you like to get here at a certain time, you're going to see an epidemiologist, you're going to get all this is what's going to happen afterwards. And some of the things that happen in the prehab, the last question, or the last one you had, are what patients are actually interested in hearing. So it's good to know all the procedures, like here's where you park in the parking lot A, you go in building B, if you're getting this down. But that information tends to ramp people up, is what we found out. While this information, when they receive this thing over here with what's wrong with you, you can answer 3 or 4 out of the 5 questions we did. That usually turns the ramp down and increases surgical success rate afterwards. That's where a patient becomes much more satisfied. So without answering them and we're just leaving them with the regular questions, we found out that patients will become frustrated, irritable about the outcome of their surgery, and sometimes even really angry that they even had the surgery. Answering these questions toward the end will actually increase the chance of the patient wanting to go back to the surgery, wanting to get another surgery, feeling that was a great experience. afterwards. And then the one you had over there, you know that no metaphor was the best. This seems to be the one that patients tend to understand the most. When they ask what's wrong with me, usually it's that model that they go back.
Yes, can you put it back to the question, please?
Yeah.
Would you be able to do that, make it into a laminate? Like,
Oh, laminate?
That can piggyback to our NRC health survey too, if we keep on working that.
Sure. Cool. Cool. I think the use of like P&E is useful for tempering patient expectations. You know, I feel like if we just go through the procedural stuff and you kind of explain what they should expect, even though their outcomes don't change at the end, they'll still have a better understanding of what's happening to them, and that kind of makes them feel more empowered at the end of it. At least based on the lectures I've followed for this. Yes. But yeah, spine surgery is a really like hits home topic to me, like I was talking about earlier. I got it in my undergrad. I didn't know what was really going on, and then as I got more educated, like I kind of learned to appreciate better, but I didn't really understand it at all going into, and I kind of felt frustrated and kind of was falling into that failed surgery syndromes. But I think learning more about this stuff, feeling more of that functional outcome and patient empowerment, it makes someone going through that feel like there's at least hope for things to get better when they don't feel like it's going to. But yeah, and that's why I picked this topic today.
And then in the military study, what made him get 100% outcome of that? Is there something they did?
I mean, that military study, if anything,
they were ordered to get back.
Yeah, they have to go back within 3 months or else, I guess. But yeah.
That's great motivation.
Yeah. For sure. A lot of this stuff too is like there's a lot of like brand kind of like selling and trying to advertise new parts, and they don't do a lot of the studies by themselves anymore because patients are getting more complicated. They're trying to see what combination of different surgeries will lead to best patient outcomes, but I kind of try to find studies that would just specifically, I guess your most common, they're only going to get one, so I guess the most day-to-day ones you're going to see, not the complex cases. And that those complex cases is going to be more clinical judgment, stuff like that. But yes. If there are no questions, it was a sincere pleasure presenting to you all. I hope the food was good.